Hello, friends. I'm Dr. David Brown, interventional cardiologist, founder of the Heart Hospital Baylor Plano, and your host for Heart Talk, the podcast that we hope will be number one in your hearts and minds. Today, we're thrilled to be joined by Dr. Robert Smith, the chairman of cardiovascular surgery at the Heart Hospital Baylor Plano and medical director of cardiovascular surgery for Baylor Scott White. Dr. Smith is renowned for his multidisciplinary approach in the treatment of cardiovascular disease. He has been instrumental in developing the concept of the heart team. He is a principal investigator for multiple groundbreaking transcatheter valve therapies that are poised to revolutionize cardiac valve treatment. Please join us in welcoming Dr. Smith to this episode of Heart Talk.
You're listening to Heart Talk with your host, Dr. David L. Brown. Dr. Brown is an interventional cardiologist, innovator, and co-founder of the Baylor Scott White, the Heart Hospitals in Plano, Texas. He now serves as president emeritus of the Heart Hospital's medical staff. And now, here's your host, Dr. David Brown.
Rob, thank you for being here. We're thrilled to have you.
Yeah, Dave, thanks for having me. It's awesome.
We are going to talk about heart surgery and everything subspecialization in mitral and tricuspid valves, as well as quality and a few other things. But before we start, Rob, let's do a little bit of rapid fire and maybe just a little bit of revelation of personal things to the audience and tell us who you are. So let me start with a couple of questions for you. Favorite U.S. city? Fort Worth, Dallas, other?
Fort Worth.
Fort Worth. Sounds
close to San Antonio.
Okay. Grew up in San Antonio.
Mm-hmm.
Went to high school there.
Mm-hmm.
What high school?
Alamo Heights.
Alamo Heights, of course. Played football there.
Mm-hmm.
Position?
I was a mule.
Position?
A cornerback and a receiver.
Okay. You're a big griller at home, right? Favorite grill? Weber, Green Egg, Traeger?
I love the green egg.
The green egg wins going away, right?
It is the perfect versatility barbecue unit for any household.
Okay, you and Susie have 4 kids.
Not sponsored by Green Egg, unfortunately. we need to work on that.
Okay, I like that. Well, or at least get paid for it.
Yeah.
You and Susie have 4 great kids.
Mm-hmm.
A couple playing big-time rugby, state championships maybe.
Yeah.
Your favorite sport these days, rugby, football?
Anything my kids do is my favorite sport. So rugby. So this has been fun. My 2 youngest boys both played rugby at Jesuit. Both ended up getting state championships. When the first one got the state championship, it was up to the youngest one's team to then live up to that. And fortunately, he played with a great group of I'd say kids, young men. Man, are they just really dedicated to doing a good job and love how they did it, the sportsmanship that they showed throughout the year, the hard work they put in. It was cool watching back-to-back and watching both your sons get to be on those kind of teams.
And yeah, how fun is that? And you have a brilliant daughter, Bren, who is, I believe, a cardiac ICU nurse.
Yeah, she's a CVICU nurse, so she didn't stay too far away. Yeah, she's working at St. Thomas Hospital in Nashville, working with a good friend of mine who also does robotic mitral valve surgery, Avelio Rodriguez, and she brags on their team, and I'm like, it's great, honey. I'm super happy for you. If you could have just been a nurse here, you would have been on a better team.
So we can get her back here. Another son who's heading towards pre-med. Yeah. What's the over/under of 4 kids going into medicine?
So into medicine, the larger medicine, we're going to have 50%.
Okay.
My oldest son, Asher, he's applying to med school right now. The 2 younger ones have 0.00 aspirations of going into healthcare.
Okay. Let me see if you can answer this question. You may not be able to. Undergraduate, you went to TCU, wanted to be a Horned Frog for some reason. Why?
It turns out that is where God put all the angels. And I figured I better get there quick. And sure enough, I found my wife there.
How great is that?
And honey, that was for you. Yeah. So I expect really awesome stuff when I get home.
Yeah, Susie, that was a commercially paid announcement. And you played football there. What position you played football?
I was a safety.
LaDainian was after you.
Well, after me. Yeah.
And we touched on Max Nocky, great quarterback, and a nephew of one of my closest friends from West Point.
Max was a really good quarterback, especially in the setting of when we played. That guy managed to do a lot with that team.
So TCU, at what point in your life do we know you're going into medicine?
So medicine started out actually in high school. So I was bound and determined to be a lawyer like my dad up until I turned 16. My mom had a stroke here in Plano. Yeah, it was a pretty devastating event, but it totally changed what I was going to do with my life. And I recount this story and have been recounting this story for every of the 9 million wannabe med students who come and ask you, why do you want to be a doctor, and why do you want to be a doctor? So the deal was, the outcome was not good for my mom, but the experience of what I went through with the neurosurgeon who took care of her, treated us like people, not like she was just some patient, had a very caring soul. And I was like, if I'm going to do anything in this world, I'm going to do that. And so I just kind of switched up what I was doing. Now, did I trip up along the way? Sure. Lots of second thoughts.
We all do.
Yeah, but no, that drove me to get through TCU, playing football, going to class, keeping it straight, then going on to med school and kind of coming up with ultimately what ended up not being neurosurgery and eventually becoming CT surgery. But all along the way, I thought I was really patterning myself off of what I wanted, which was I wanted to do that. I wanted to be the guy who came in and even when it was bad news, could deliver care.
That sounds like an interventional cardiologist. I think you missed the shot, but pretty close.
I don't think you know many interventional cardiologists then. I'm just kidding.
Yeah, I mean, that was the idea. 3 o'clock in the morning, let's go open that artery.
Yeah,
so
I think what's great is I get to work with a lot of like-minded people.
Right.
Who's you go and you ask everybody their story, and they may have a different reason why they got there. And hopefully they have a different reason why they got there, but they got to the same place.
Right.
We all got in this because generally there's a lot of good people out there in the world wanting to do good things.
Well, in cardiovascular medicine, especially the interventional cardiology, cardiac surgery side, has always, almost seemed romanticized to me. I mean, just what you said. I mean, we get to basically save one life at a time, fix one person at a time, and do it really well. So that part's kind of fun. Somewhere in there, real quickly, though, the neurosurgeon influenced you, and you went through this path. Can you remember, or is there a trigger moment that goes heart surgery?
Well, that was a little bit more of a development. So I had some great mentors along the way, some really great mentors, and none of them were really pushing me into heart surgery. I kind of felt like I loved medicine, and I'd jump from one topic to the next, kind of going, oh, I love this and I love that. Eventually, I really settled in on surgery, and I did my training at UVA for my general surgery and cardiac surgery training. And I actually wanted to be a pediatric surgeon. There's a guy there named Brad Rogers who was a phenomenal surgeon. He's a pediatric surgeon. And I was like, I love what this guy does. I love the whole, pediatric surgery, and I want to do liver transplant as well. And along the way, I spent time in the cardiac surgery room and in the ICU. And I was like, there is just nothing more attention grabbing, have to pay attention to every detail, have to be in the moment, every moment in order to make a good outcome. And I was like, I just feel like this is what I was built for. And so I fell in love with cardiac surgery along a long path, but man, when it locked in pretty hard.
No matter what the nephrologist and neurosurgeons say, the heart is still the center of the universe, right? I mean, ultimately, you have to pick that.
I'm sure there was some of that went into play as well. I was like, you know what? Really, no one can kind of do it without me.
Right. So internship, residency, fellowship in general surgery, cardiothoracic surgery, all at UVA,
All
right?
at UVA, yeah.
And then eventually started looking for a real job, trying to be a real heart surgeon, right?
Yeah.
And interviewed around the country, a lot of good job offers, and interviewed with us at the heart hospital, right?
I did, yeah. mean, I was, again, like I said, I've been blessed with some really great mentors along the way. One of those mentors, Irv Crone, who was, I mean, just a great educator and a great teacher of life, particularly how to deal with, what is it that you want? What do you think you need to be happy? And kind of taking all those factors into play. And he did all that without saying a whole lot of words. He was just very concise in the way he would help you. And I appreciate him knowing a lot of people, getting me in touch with Dr. Mack. So Mike Mack, your storied partner. And it came down for an interview here. And it was the only time I interviewed where I went out to dinner with as many cardiac surgeons as I did cardiologists, all at one dinner. And that was, and with wives and everyone, I was like, this is unique because everyone cares about who you're bringing in next.
I don't remember the name, but we still remember the Italian restaurant. Remember where we were, the table, where we sat, right? It was a terrific interview. And, the talent that you brought was something that we really wanted. And skipping forward just a step, I think Mike gets credit for it. Mike Mack gets credit for it of lining that up and saying, look, why don't you come join us? You're hired and would love for you to go train with the emperor of cardiac surgeons in Germany. So Fred Moore, Leipzig, Germany, started the program after the wall came down. Tell us about that a little bit.
So a great opportunity. Mike and I had already talked about the job here, and we're lining everything up. And I met Mike at one of the early kind of regional valve meetings at the Florida Valve meeting. Mike Borger happened to be there. And of course, Mac, who can imagine to change somebody's life in about 15 minutes and putting a little bit of thought in it, kind of could see from an upper level what needed to happen to make Rob Smith successful and the things that I was interested in doing. And he was like, this is what I think can happen. They do these travel fellowships through the AATS, one of the surgical societies. Mike Borger here works in Germany with Fred Moore. It is the epicenter of all things new and important in heart surgery and in the up and coming world of structural heart transcatheter therapies. And we need to get you there. How do we do this? And so he's like, there's these travel fellowships. This is how it's going to work. This is how we're going to do it. And lo and behold, next, I finished fellowship and I dropped my wife off here. And in a week, I'm out the door and on a plane to Germany and to Leipzig, Germany, where I show up with 2 gigantic suitcases and show up at the hospital. I'm like, I think I'm supposed to be here for about 3 or 4 months. And I didn't know a lick of German. And it all worked out great because Fred Moore is everything that Mike Mack and Irv Crone were. He is another one of those mentors that I've been blessed to have. Had basically set up to where I could spend 4 months with them out there in Leipzig, learning transcatheter therapies, learning minimally invasive mitral valve surgery, which at the time he was the epicenter of all those things and had popularized it, had introduced the world to robotics with Carpentier, and was kind of leading the education of the world on how to do transcatheter therapy and how to work with cardiologists as a team, and with picking the right team members. You and Mike were part of that team as well. So I am, again, thankful to Irv, Mike, and Fred for all the things they set up.
Hard to have a better mentor than Fred. And for the audience that doesn't know it, I mean, this was the emperor king of cardiac surgery in Europe. Spawned more chiefs of cardiac surgery programs, they say, than anybody since Professor Bill Roth in the mid-1800s, right?
Yeah.
And just an extraordinary person that took this place that was decimated in East Germany when the wall came down, over 25% unemployment, and turned it into the center, Herzenstrom, and did over
Leipzig,
and did over 5,000 heart surgeries a year. An extraordinary place. What a great place to start off and learn some training.
It looked like Fort Worth on the outside, and yet did numbers bigger than anywhere else in the world. And again, like you said, this was old East Germany, so you're walking through town. There had been a lot of development by the time I'd got there, but but not to the level that it even is today. And you see old row houses, old kind of, Soviet apartment style things. And then you go into this hospital and there is the latest, greatest gadget in every facet of cardiovascular medicine that you can imagine.
But before we leave it, I'll just one comment of, as a U.S. cardiologist, I feel privileged to this day to feel like, as a mentor as he was to you, Fred Moore really became a partner to me as a heart surgeon on a different continent, in a different world. And he was extraordinary for me. And obviously, the relationship with Mike and me, so it was unbelievable. Let's go into your career. The subspecialization part. You're not totally or only a mitral and tricuspid surgeon, but I feel like that is the intensity of where you've directed your desire efforts, mitral and tricuspid, both in surgery and transcatheter. Can you just give us a little background?
Yeah, I mean, a big part of why I went to Leipzig was to learn minimally invasive mitral valve surgery. So again, touching back on the mentors. So I've had Irv Krohn, Mike Mack, Fred Moore, and then Will Ryan. And so Will Ryan, kind of the consummate surgeon, the guy who could do everything well, but had been in the U.S., one of these revolutionaries in the minimally invasive world, who had started turning open mitral valve surgery into minimally invasive mitral valve surgery with excellent outcomes. And I got to be his partner in trying to develop that here in the Plano campus. And I learned a lot from him. And what I learned along the way is it takes time and effort to be really good at this.
We're proud of the fact that we have a 105-bed hospital and effectively do 2,000 heart surgeries here a year. As we talked about last night, this year, as we approach the 10th year anniversary of opening Denton, we talked about the fact they almost did 500 cases out there this year. I think 491 in a stunning fashion with a 26-bed hospital.
There are programs in this city that have existed for 50 to 100 years who don't do 500 hearts a year.
Right. The final touch I wanted to put on that was something that you may remember. When we opened that program, as you pointed out, we really had no foothold there. Baylor had no foothold there. They had no primary care out there. And we had longstanding cardiology partners who had been there for a number of years and were begging to put this thing together for that geography. Tung opened that program and asking him to do heart surgery and don't kill anybody. He did it, and they did it with zero mortality for the first 3 years of a heart surgery program. To me, that's extraordinary in this country, just unbelievably good. And you pointed out, they have 3 stars in that category as well. I think the combined programs, 2,500, heart cases, just crazy good. We have almost 10 trials, maybe 10 trials in mitral and tricuspid.
We've got trials in mitral valve where we're using devices that clip the valve and kind of put the pieces of the valve together in the middle so that we can see if that works. We're looking at new devices, comparing them to old devices. We're looking at transcatheter mitral valve replacement. Is this a therapy that can take over surgery one day? And in the tricuspid space, which is where I think the real world of change is happening right now, is we're looking at similar devices where surgery has historically been a difficult ride for patients, and we're working on changing what we do.
I think we probably have actually a dozen active and enrolling trials and pipeline trials right now for those things. You touched on a bunch of them, but CLASP, Pascal, TriSend, and even a Monarch EFS. EFS has come back to the U.S. for the first time after a couple of decades. Comment?
Yeah, so early feasibility trials, these are, some really, really smart guy in a garage somewhere is like, I've got a great idea for a device.
Right.
And this really, really might work. And, you test it in animals first. You come up with a concept of an idea, you test it in animals, and now all of a sudden now it's got some promise. And we get to first in man, and first in man looks like that was maybe a good idea. And now we've got early feasibility.
Fundamentally, you starting out with some minimally invasive surgery, doing surgery for mitral, surgery for tricuspid. So we said Will was one of the leaders in the country, taught it a lot. And it happened to be at a time where TAVR comes along, and sort of for the first time, we're going to do something transcatheter. We're going to replace an aortic valve with what Mac used to not like me to say, no incisions on your chest, no incisions anywhere in your body. Just want to pat the chest, the valve's going to go in, obviously with a stick in the femoral artery. But in doing that, it was really the early phases of this whole transcatheter revolution with the aortic valve that's now moved to tricuspid and mitral. And what came of that is Mac and I are, I'm going to say, a little proud of the fact we believe that we helped create the heart team before country was cool. And the heart team is near and dear to my heart. Yeah, I think it's as near and dear to your heart as mine, anything else. Talk about the heart team a little bit, and then we'll maybe come back to transcatheter.
Yeah, I keep, every time I talk about a trial or something like that, I'm not saying surgeons, and it's on purpose. It's because it's a team, all right? It's a team of providers that get together and think these things through. So in any of the trials we talk about here, it's interventional cardiology, working with cardiac surgery. And by the way, the real heart of that team is our cardiac imagers, right, who are just kind of telling us what to do, who are the real...
And they're pretty good.
Yeah, exactly. And they're the real brains behind
right.
these things. But it's like no procedure is really complete without, what is the impact on the electrophysiology of the heart? All these patients come in heart failure. So how are we including our heart failure folks? And, unfortunately, a lot of these diseases affect patients who are extremely elderly. And what happens when we don't have somewhere where we can go with this? How are we getting our palliative team involved in these kind of heart team discussions? And by the way, the surgeons are involved in this too, because we're trying to bring years and years of experience, training, passed down knowledge that has come from generations before us to a brand new stage, which is the transcatheter world. And I have big hopes for transcatheter, mitral, and tricuspid. We're in our nascency. And I think TAVR it is a completely different pathologic state. It makes itself very amenable to the intervention that's come about. Mitral is just hard. And I would say mitral surgery is hard. Transcatheter mitral is hard. Why is it hard? It's complex. That being said, there's some really smart folks out there in this world, and engineering every bit of what we do with heart surgery eventually can be done. We just got to give it the time, the patience, and the energies to make it happen. But I think we will eventually get there.
Yeah, as you say, there was certainly a time as TAVR matured in the aortic valve that there were plenty of people saying, well, the next frontier is transcatheter mitral valve. And, there's so much more mitral valve disease than the aortic stenosis that we find. This should be taken by storm, and the volume will overwhelm TAVR. Hadn't quite worked out that way. And probably the same thing with tricuspid, two very complex valves, particularly understood by the great heart surgeons. And as you all figured out, it's a whole lot different challenge than the TAVR that we did. So that sort of segues into, here's an attachment, robotic surgery, especially robotic valve surgery.
And this is now truly in the surgeon's domain, but I think it's one of these issues that it adds complexity to the depth of conversation that we need to have with patients, which is we're no longer talking about surgery the old-fashioned way, which is dividing the breastbone, doing surgery through this big morbid approach. We're now talking about minimally invasive surgery that's not even spreading the ribs. This is small holes in between the ribs that when we come out, they have like at biggest a centimeter incision. I mean, yes, TAVR is a no incision. I get it. I will always be corrected on how small we can go. But I mean, we're talking about surgery now that we consistently talk about sending patients home who are appropriate quality. Send them home the next day, the day after that. I mean, post-op day 1, post-op day 2 kind of discharges. There is no way 10 years ago I would have ever thought that was possible. And looking forward, and here it is, I am constantly trying to go, why does that patient need to be in the hospital? What service are we providing them? How are we making their lives better? All we're doing is waking them up early, right? All we're doing is drawing an extra lab. I don't know that that's doing them any good. So maybe they should just sleep in their own bed.
That's exactly what happened whenever we started AAA transcatheter stent grafting. We'd do the case, and this was obviously in the late 90s, the blend of cardiologists going and surgeons not so enthused about your jumping in the fray, but doing it together. We'd do the case, and fundamentally, all they had left was they had a little needle hole that was kind of like a hard catheterization. They go to the floor, and the nurses are going like, okay, what are we supposed to do with them? Well, I think we're going to send them home. Well, I mean, they just had surgery. Well, yeah, but okay, let's get up and start moving. So, I mean, we're running through the same thing. We've run through it in TAVR, headed that way, mitral and tricuspid. Really exciting time to be there.
I mean, what's great is cardiac surgery and interventional cardiology get along so well because they require each other. Cardiac surgery is here to slow down interventional cardiology. And interventional cardiology is here to speed up cardiac surgery. And somehow in there is a synthesis that is good for patients.
That's a great line. I think that we should all adopt. I'm going to say it's what you just said is not true in every institution in this country. There is not always that collegiality and camaraderie between surgeons and cardiologists. There's arguably a lot more competition in plenty of places, and maybe even sometimes, ill will and other things about it. Plenty of places have kind of figured out and joined the heart team phenomenon. But I feel like at that level and that level of culture, we lead the league in heart team and collegiality between surgery and cardiology. I think it's extraordinary. Turning back to quality, that I've had led the effort for 2 strategic retreats entitled Zero Mortality in Heart Surgery. When I first had this conversation with your mentor and partner and buddy, Will Ryan, he kind of told me I was crazy and I was a cardiologist, and people die from heart surgery. And a few years later, we'd go through a year in certain arenas, starting with aortic stenosis, and nobody died. And it's become a mantra here, I think, of zero mortality in heart surgery, and that we aim for looking at our quality reports and looking for a goose egg, a 0, or at worst a 1, essentially a binary random variable. Like, okay, we had 1 death last year. We had 0 deaths last year. I feel like that mentality by our heart surgeons, your heart surgeons, has led us to this point.
Thank God for Dr. Ryan, Dr. Mack for pushing us all to develop that culture. And thank God for the guys that we have now who have adopted it as their own to say that we can do this. And so, we've got now well over 600 cabbages with 2 mortalities over a running 12 months. You'd be hard pressed to find something that's that good.
I want to pile on to a big compliment to our surgical program, to your partners, to our surgeons, and really to Tim George as well. And something that he said.
Qualifies as one of the surgeons in the program.
No,
he ticks all those boxes.
He's it. No, and it's not that he's not in that category, but it's specifically something that Tim said in line with what we're talking about. And he challenged the idea of aiming for zero mortality in heart surgery, in that questioning something philosophically and ethically, if we really are a program that takes all comers from a clinical standpoint, how do you decide who to turn down? When do you turn them down? And this is really the tricky part of cardiovascular medicine, both in cardiology and cardiac surgery. When do you stop? And I feel incredibly proud of what the guys have done, what our program has done in taking that and taking somebody that's further out on that risk spectrum, that arguably has such a high level of risk of dying, that there are places and programs that wouldn't do it. Now, we know there are programs and surgeons who will do anything, which is not the right answer in my mind. But Tim defended that point very well of taking patients and taking some risk, that this is not, a 7 no Trump lay down and bridge. This is not guaranteed, but I think we ought to do it because this person might live another 5 years, or to your point, might have another quality of life for 2 years. It's beyond, their non-existence right now. And I think he represented that for the program incredibly well. And yet, as he and all of you have done that, it hasn't really dented the incredible statistics that have led to 5 3-star ratings.
Yeah, I think that gets back to, just because we have a high-risk case conference, again, this is not just a big group of surgeons talking about this stuff. This is a multidisciplinary discussion. I can't tell you how many times we sat in that conference and someone's like, yes, this looks like surgical disease, but that patient beyond your typical 30-day, outcome mark is not going to make it a year. So let's have a different discussion about what does it look like if this patient doesn't live a year with the best of coronary arteries, right? What if they don't live a year with the best valve situation? You know what? That's a different perspective. And historically, surgeons have known what their 30-day outcomes are and have had far less knowledge and insight into what those 1-year, 5-year outcomes are, other than, some big graph presented at a national meeting. And now we live that with our cardiology partners. And I think that makes a big difference as to how we evaluate these patients, how we talk to them, how we go over risk benefit analysis with them. Who do we bring in to have that discussion with us? And I think that's a big change over a long period of time. And a fundamental piece, though, of how we've gotten here is the multidisciplinary heart team approach that does not just include cardiac surgery, even interventional cardiology, but your palliative care partners, your heart failure colleagues. Did you have that extra talk with your primary care physician who's involved in this case? I want to say that's not unique in the United States, but it is unfortunately not as well developed at other programs.
The most recent U.S. News and World Report rankings were just released, and we were ranked 30th in the country. As you well know, we've talked about it, studied it, looked at it, and I think it's still in rarefied atmosphere. We are a 105-bed hospital. The programs that are on this list and ahead of us are names that everybody knows. And sometimes it's hard for a startup that's only 20 years old, as the Heart Hospital in Plano, the Heart Hospital Baylor Plano, hard to be known on the sidewalks of Omaha or something else. But it's something that you and I, we are incredibly proud of how that quality has translated to that national recognition, and even our volumes. You look at heart surgery, you look at valve surgery on a national basis, and volumes, we're second to Cleveland Clinic, right? And what does that mean? That means ahead of Mayo, Cedars, Columbia Presbyterian, NYU, Norfolk Centaur, Mount Sinai, St. Francis. Everybody can name down the top 10, down the top 30. Again, emphasizing the quality with the 5 3-stars. Most of all these programs are over 100 years old. A lot of these things, were established in like 1868 and 1907. This program is less than 20 years old, and I personally feel like it is at the pinnacle of heart surgery in this country, of cardiology, interventional cardiology. Our heart failure guys, EP, all put that together to put us on that list, 30 as it is without name recognition. Maybe a good jumping off point, comments about that, and we'll try to wrap this up.
Yeah, I think when I think about what goes into U.S. News and World Report, number one, interestingly, right, it's all your data from 2 years ago, basically. Well, our data from 2 years ago looked as good as it does today. So great. So we know that the data for outcomes, how patients do when they leave the hospital, is solid. But it takes into so many different factors than what the STS star ratings does. So the STS star ratings is cut and dry data. Morbidity, mortality. How do you do? The things that you want to make sure you know about what your mom's going to do when they leave your hospital. This takes into what's your reputation, what are the things you have at your hospital. We don't have transplant at our hospital, okay? Despite not having transplant, you know what? We deliver 3-star outcomes in 5 different categories of cardiac surgery, the only 5 that we look at across the country. And we do it despite not having transplant somehow. to me, it didn't change the way we deliver care, not having transplant. We delivered the best quality care. And that not having a transplant program here in a scoring system dings you. Your reputation score dings you. You know what? A lot of people didn't drive Teslas for a long time. I see a lot of Teslas on the road. You know what? We're the new electric car. So just watch out.
Rob, thank you for being here today. I can't thank you enough. I was excited to sit down with you to hear about our surgery program and about all the things that you guys bring to this quality piece. So thank you for being here. We'll have you back another time to take a deeper dive into robotics and a little bit of transcatheter mitral valve, tricuspid valve as we go along.
Love it.
Thank you, buddy. Appreciate it.
Appreciate you.
Views and opinions expressed by Dr. David Brown are his own and do not necessarily reflect the views of the Baylor Scott White, the Heart Hospital, or any of its officials. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of any of them or any entity they represent. The information provided herein is considered educational and should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies.